Building Consensus with EHR by April Starks Marshall, Anthony Yotis, Brittany Swirls, and Ali Spangler. Objectives: define and understand electronic medical records. Understand how electronic health records work. Compare and contrast EMR versus EHR. Identify the changes and disadvantages of EMR. Understand how paper systems are converted to EHR. Understand the EHR implementation process. Define and understand meaningful use and its implementation. The definition of healthcare records is the digital version of patient data found in traditional paper records, increasingly used to refer to a longitudinal record, ideally of all healthcare encounters. EHRs have changed the way healthcare providers and nurses deliver care. Gone and eliminated are the days of the patient files as thick as 2 phone books. No more papers in random order flying out of the sides of the binder. With the click of a mouse, a nurse or healthcare provider can access patient information in seconds. This has improved quality of care by reducing the time needed to acquire important information from the patient's medical record, especially in those emergent situations. The electronic health record is composed of health-related material for an individual that is accessible to more than one healthcare facility, has the ability to record patient information over a lifetime, considers the patient's overall well-being rather than specific illness. Transfer between hospitals will be smoother, providing continuity of care. The continuity of care between healthcare settings is easily maintained. Lab tests and x-rays are uploaded immediately for examination between the disciplines. We'll have the capability to be accessed on various types of computer programs between various healthcare systems. Patients would have access to records, enter data, and make those demographic changes. An electronic medical record is that legal record created within the healthcare facility, accessible to only employees within the facility or office. It is the building block that comprises an electronic health record. It is typically referred to as a single encounter, which means limited ability to transfer data from one institution to another within the same healthcare system, whereas printouts of medical records must be delivered, which compromises confidentiality standards. Some components of the EMR order are order entry, clinical messaging and email, decision support, and data repository, generally specific to illness rather than full scope of wellness. Here's some pictures of how the current paper systems look: disorganized, not getting that good continuity. You have the electronic medical record, which is in your office. You have your electronic systems, but it's only confined to that office. With the electronic health record, as you can see, it is a span of information, that ability to spread that information out across a continuum. You have your integrated practice management, your electronic ordering and lab results, those e-prescriptions, the information sharing, the mobile access. The transition from paper to EHR. Before the process of converting those paper files to EHR, we have to start with some questions. Which historical patient information should be available for patients' visits during and after the transition? What are those best methods of converting this information to an EHR? What is the best way to ensure that that converted data and information is sufficient quality? How long do patient records need to be kept after the transition to EHR? There are key members of that healthcare team that will need to be a part of the transition, which may include the physician, the physician's assistant, and nurse. These individuals will provide insight on document and data needs for the patient care. There are different options for the transition. Scanning paper charts and uploading them to an EHR system. It is done by outsourcing the scanning to a third party. The advantage is that all paper documents become obsolete. The disadvantage is that it can be very costly. Another option is to scan nothing, keep the paper chart, and start the EHR on the patient's next visit. There's advantages that the money saved is by not having to scan the documents. Unfortunately, the paper charts never really tell the complete story of the patient. The nurse would have to refer back to the paper chart when needed, which is time-consuming and leaves room for errors. The final option is to scan only what is needed. The advantage of this is that it is cost-effective and time-efficient. The physician would determine need-to-know information through the patient's health record. The staff would then scan the information into that EHR. This is the most effective method and the least costly over time. Some advantages of EHR. Records accessible to many people at remote sites at the same time. Information retrieval is almost immediate. Easily identify which patients are due for preventative screenings or checkups. Check how patients are doing on certain parameters such as blood pressure readings and vaccinations. Enables multiple users to have access to the records that are organized, legible, and complete. Tracking data over time. Improvements in the quality of care. No longer have the issue of illegible orders. Reduction in medical errors. EMR systems can integrate evidence-based recommendations for preventative services with patient data to identify patients needing specific services. Electronic data is compact, easily stored, and easier to disseminate than paper data, which increases storage capability. There's higher patient satisfaction with EHR. According to Duffy et al., 92% were happy with their doctor using e-prescribing. 90% reported rarely or on occasion going to the pharmacy and not having that prescription ready. 76% reported obtaining medications easier. 63% reported fewer medication errors. Some disadvantages of EHR. You have temporary loss of productivity associated with the adoption of EHR. Maintenance costs. Obligations to know the entirety of the exponentially increased volume of data included in that electronic chart. High startup costs, including adoption and implementation costs. If electronic health records and paper charts are not accurately coordinated, physicians will have to check both to avoid that malpractice risk. There's a learning curve associated with adopting the EHR, learning the technology, the different technology terms. It is capable of being hacked and other malware issues, and requires the data keepers to meet a higher standard of protective care. Implementation of EHR. Some goals set to support the company's vision and mission, strategic planning, selection of the steering committee, assessments of needs and wants, selection of vendor process, selection of EHR system, training of staff and clinicians including that buy-in, go live, follow-up and maintenance. Strategic thinking is that process an organization uses to determine what its future should look like. Strategic planning is the process of determining what an organization wants to be in the future and planning each step. It will define the corporate mission and scope to the community it serves, specify achievable goals and objectives, developing strategies, setting policy guidelines, complete a SWOT analysis, which is the strengths, weaknesses, opportunities, and threats. The strategic planning team includes board of directors, chief executive officer, chief strategy officer, chief financial officer, all of which has the staff of lower management to supply the data. Lower management consists of all department heads. The life cycle rotates in 4 phases. You have your needs assessment, determining the overall costs of the hardware and software network implementation. You have choosing a vendor with appropriate qualifications and experience, reputation. The knowledge begins with a request for information. In choosing software that has ease of use, minimal training, functionality identified as musts, supports security requirements, supports interfaces with other applications. Training focuses on developing a plan to train staff and clinicians with varying backgrounds, providing them the knowledge needed to work with information systems in a clinical setting. Workplace training environment is the mock program which mimics the actual program with fictitious patient information to train with. EHR and COP super users are clinical and IT employees with additional information system training, serving as mentors to assist clinicians with the training process, which then increases compliance and buy-in, especially among our physicians. Implementation of EHR. Go-live training is the date when the actual system will become operational and using and providing actual client data. The data is determined by the implementation committee. Production environment is used to describe when the system is in operation, which includes implementation strategy, such as staggering, modular all at once, conversion to a new system, which information will be backloaded, such as orders, developing support schedule, on-site support around the clock initially, evaluation procedures, evaluating the satisfaction among users and method of communication for questions and answers, request for post-go-live changes, priority changes needed as the system is implemented to maintain functionality and usability. The system installation. Once system is in use, users are expected to make the switch from manual or prior information systems to the new one. The maintenance, user feedback and support. Communication is really important. Results from evaluation surveys should be compiled, analyzed, and then those results shared with users and IT staff. Usually there's a help desk maintenance support that also provides round-the-clock support, and it's usually via telephone. System maintenance should be provided in all three areas: test, training, and production. Technical maintenance pertains to the technical and equipment issues, and the IT department is usually included in the debugging and problem solving, file backup, system upgrades, and maintaining monitors and supplies and printer cables, etc. Meaningful use is that government standard that defines how electronic health records are to be implemented in exchange between healthcare organizations, insurance company, and patients. It is the major driver for the EHR implementation in the U.S., and it is legislated by the Health Information Technology for Economic and Clinical Health Act, or otherwise known as HITECH, and of the 2009 American Recovery and Reinvestment Act. CMS reimburses healthcare organizations for meeting these meaningful use criteria while implementing their EHR. Technically, it's voluntary. CMS incentivizes EHR use by monetary reimbursements for meeting those proposed timelines and penalties for failure to meet those timelines. Components of meaningful use: track, record, exchange information, including CPOE for medication, laboratory and radiology orders, electronic prescriptions, checking insurance verification, submitting medical claims, exchanging of clinical information, maintain privacy and security, record patient demographics and vital signs, submitting captured quality measure data. Electronic copies of PHI are provided for all patients. There's 3 stages of meaningful use. The stage 1, 2010 to 2012, really promoted the adoption of EHR use, included that e-prescribing, lab results available, summary sent providers, report of public health and quality data results. Stage 2, which is occurring between the years of 2013 and 2016, criteria compliance is enforcement increases, along with more clinical decision support, coordination of care, and patient engagement rules are introduced. It also includes the e-prescribing and PHI patients can access, health alerts, and more. Stage 3 is 2014 to 2016 with the continued focus on health information exchange, including other hospital and medical systems access to comprehensive patient data and real-time surveillance. The Centers for Medicare and Medicaid are currently in this process. Implementation of meaningful use. The EHR is well on its way to becoming standard practice for all healthcare-related businesses. While it's currently voluntary to participate with Meaningful Use Initiative, it will soon become law as CMS rulemakers continue to write mandates in addition to offering incentives for compliance and penalties for noncompliance. HITECH brings consistency to EHR implementation among healthcare systems, which improves EHR adoption efforts within the U.S. In conclusion, building consensus for EHR is compared to building a village. It takes the efforts of the entire healthcare system to buy into its use, seeing the vision of its benefits in the long term for our patients. Increased continuity and quality of care across the healthcare continuum, reduction of medical and medication errors, and increased productivity while implementing EHR systems outweigh the old practice of handwritten paper systems which put our patients at risk for medical errors, which could have critical consequences. As technology continues to advance, and in our world where evidence-based medicine is the future agent of change, The electronic transfer of healthcare information across multiple disciplines is fast becoming the standard of care, building consensus among healthcare professionals and our patients alike.